I thank the gentleman for yielding and heading up this very important special orders on a topic that affects every single family in America, and that is their health. As the gentleman said, yesterday we passed a very important bill, the 21st Century Cures Act, with the charge led by Chairman of Energy and Commerce Fred Upton. And I was pleased that they included in that package our mental health reform bill, which we moved out of Energy and Commerce Committee unanimously over July. We have spoken about this issue at great length for the last few years because it is worthy of that time. We've spoken because of the 60 million Americans who suffer from some level of mental illness and the 10 million Americans who suffer from severe mental illness, and the fact that 40% of them cannot get care, and that half the counties in America have no psychiatrist, psychologist, or social worker, that we do not have enough hospital beds for people in crisis, a shortage of 100,000. That there are only 9,000 child and adolescent psychiatrists when we need 30,000. Particularly important because severe mental illness in half the cases emerges by age 14 and 75% by age 24. That we've seen too many lives lost, that the body count in this nation last year, related primarily and secondarily to mental illness, exceeds the total combat body counts of the United States soldiers in World War I, Korea, Vietnam, Desert Storm, Bosnia, Afghanistan, Iraq combined. And because millions of families continue to suffer, because our prisons are filled with the mentally ill, our emergency rooms are backed up with people with mental illness-related disorders, and because our morgues are also filled. But yesterday, the House took definitive bipartisan approach in changing that trajectory. The issues we've covered on mental health, along with the advances in the 21st Century Cures Bill, sets a new direction for where we need to be going in this nation to approaching health care overall. When we look at the research changes that we made in advancing cures, not only in small population orphan diseases, and also with regard to the total 10,000 diseases out there, we will be able to sufficiently more effectively identify medical disorders and psychiatric disorders early on and get them treatment sooner. One of the aspects that was taken care of in the Helping Families with Mental Health Crisis Act is a program called RAISE, Response After Initial Schizophrenic Episode. And that, as we know, research tells us that when you provide medication and effective targeted counseling early on, you can reduce the trajectory of severe mental illness, improve the prognosis greatly. But when that is not provided, every crisis moment of severe mental illness leads to other neurological damage, worsens the prognosis, and sadly increases the chances that a person will have time in prison 10 times more likely than to be in a hospital when they are in crisis. And we're changing that trajectory. New research will get us in that direction. But let me lay out for a few minutes today of where this takes us as Congress is looking to change the Affordable Care Act. People have spoken ad nauseum about the problems with that act, how it's cost families a great deal, how it's supposed to be affordable, but it's not. Premiums have gone up dramatically in double digits and triple digits over the last few years, how the deductibles and co-pays put it out of families' reach, and how it is not really a comprehensive approach because it does not stem the tide of increasing health care costs. And there's some specific reasons for that. As long as we have a system that's based on a fee-for-service model, and as long as we have a system that does not put the patient at the center of this focus, we're going to continue to have problems with cost overruns and, quite frankly, care problems. We have seen changes in the trajectory of improvements in reduction of mortality and morbidity. For example, over the last couple decades, we've seen a reduction in mortality rates for cancer, for heart disease, for stroke, for accidental deaths, for HIV/AIDS, but we've seen increases in mortality rates for suicide and also for drug overdose deaths. So this really means we need to be looking at a different kind of model. And that model is the integrated care model, the model where behavioral medicine and physical medicine work together. Why is that important? We know that a person with a severe mental illness has 75% of them will have some other chronic illness like heart disease, lung disease, diabetes, infectious disease. And 50% of them have at least 2 chronic diseases. A third will have at least 3. We know that a person with severe mental illness has triple the chance of moving into poverty. And we know that people in poverty have 3 times the rate of mental illness. But beyond that, if we look at people who enter into using the medical field from the area of chronic illness, that perhaps the first diagnosis might be anything from cancer, inflammatory bowel disease, diabetes, etc., the chances of them developing a psychological problem, such as depression, panic disorder, anxiety, is massive, twice the rate of the rest of the population. And this is where the costs begin to soar. Because when a person recognizes they have this long-term problem with pain, with doctor's appointments, with disruption of their lifestyle, with immobility, with disability, etc., it is expected and it is common for them to develop other psychiatric disorders. But we have had a system that has ignored that. And then what happens is when we ignore that, if a person has a chronic illness and depression, for example, untreated depression, it doubles. It doubles their health care costs. When there are models out there that say, let's integrate behavioral medicine and physical medicine, so that a physician, being a coordinated care model, when they have a patient with one of those illnesses, a chronic illness, they begin to treat the whole patient. The patient-centered model, the team approach between the doctor and patient there. What can it do? Well, I want to cite a study done by a young doctor by the name of Jeffrey Brenner, who was out in New Jersey. And you recognize that people with complex health and social issues have these high rates of going to emergency rooms. They're called superutilizers. Medicaid points out that 5% of the people on Medicaid account for 50% of Medicaid spending. And I might add, virtually all of those are people who have a concurrent psychiatric disorder such as depression. But what Brenner did in his particular study is he recognized that there was a number of people who had a huge number of visits to emergency rooms in a very costly way. He said, for example, nearly half of the city of Camden's 77,000 residents were visiting an emergency department annually, most often for head colds, viral infections, ear infections, sore throats. 13% of the patients accounted for 80% of hospital costs, and 20% of the patients accounted for 90% of the costs. What he looked at was models that police use called hotspotting. What are the areas of a city where they have a great deal of crime? And instead of avoiding those areas, the police would go in and work to prevent crime. Well, similar in Brenner's model, he looked at managing these patients' care instead of ignoring them. If you ignore them, they go to emergency rooms repeatedly. Studies done, for example, at the University of Pittsburgh Medical Center with inflammatory bowel disease found when you ignored folks, they continue to go to emergency rooms, overutilizers of the system, and on a fee-for-service model, it was worth it for the doctor. They made a lot of money. Hospitals made money as long as the people continued to come back.